private hospitals have steadily raised prices for life-saving medical care to a level that many New Yorkers cannot afford. Over the past 5 years, the number of people covered by the city's healthcare plan increased by just 4%, but the cost of care jumped more than 50%, with private hospital prices being the key driver of that imbalance. For most consumer goods or services, the price is made available at or before the point of sale, so customers can make decisions based, in part, on the price. In healthcare, this hasn't been the case until a few big changes that happened recently. And while there are numerous reasons why healthcare prices have risen so dramatically, contrary to popular opinion, it is not pharmacy or insurance that are the most egregious drivers of skyrocketing prices. It's hospitals. Hospital prices account for one of every $3 spent on healthcare in the United States. And we would know. The 32BJ Health Fund provides health coverage for tens of thousands of workers and their families across New York State. Our analysis has shown that hospital prices make up the majority of health fund costs, and there are many other health plans, just like ours, that face similar threats to their stability due to out-of-control hospital pricing and a lack of transparency. Healthcare costs drain resources for salary increases and expanded benefits, hurting businesses' ability to hire and retain talent, make operational improvements, and invest in growth initiatives. 2/3 of workers are covered by plans paid for from the employer's own money. So, if we don't get hospital prices under control, the impacts are felt everywhere, but especially the bottom line. But don't take our word for it. Let us show you how you can determine what you may really be paying your hospitals and how to use established tools to negotiate better. First, find your annual healthcare costs. You might have this number on hand, or you might have to ask your third-party administrator, TPA, or insurance carrier for the total dollars you spend. If you don't have that, we'll show you how to approximate it for the sake of this exercise. A good rule of thumb is 1. You probably spend about $7,739 for each individual you provide health coverage to, on average. 2. You probably spend about $22,221 for each family you provide health coverage to, on average. For the sake of example, let's say you are the CEO of Company A, which provides full family coverage to 450 employees. That's roughly $10 million a year in health premium costs. You can use this as a proxy for your total spend on healthcare if you can't get a more precise number from your TPA or insurance carrier. Of that $10 million on healthcare, about 39%, or $3.9 million, is spent on hospital services. This estimate isn't just from 32BJ Health Fund. This is the New York State average and is based on peer-reviewed research printed in Health Affairs in August of 2022. So, if you aren't sure how much of your healthcare spend is for hospitals, it is safe to estimate 39%. Next, you'll want to calculate how much greater the $3,900,000 you spend on hospital care is when compared to what Medicare pays. Medicare prices are generally used as a fair benchmark for price because they adjust for factors like geographic market and local cost of living, patient severity, and whether it's a teaching hospital. The RAND Corporation and the National Academy for State Health Policy, NASHP, both offer tools that allow a purchaser to determine how much a hospital gets paid by its commercial purchasers relative to what Medicare considers a fair price. RAND aggregates this data by state, and the NASHP tool also allows a purchaser to determine how much a hospital needs over and above Medicare in order to cover all Medicare and Medicaid payment shortfalls, uncompensated care, etc. This benchmark is called the break-even point. Break-even is important because we don't want to put our hospitals in a situation where no one is covering the costs for treating people without adequate insurance. So, we start with break-even to be fair and not jeopardize a hospital's financial viability. This will illustrate why it is so important to be proactive about monitoring what you pay for hospital care. So, back to the numbers. Company A is spending $3.9 million a year on hospital prices that are difficult to obtain or benchmark. So let's dig into this a bit deeper. Of that $3,900,000, 58.7% is how much more you are paying than Medicare if you are in New York, as determined by RAND. Any New York employer can multiply their hospital spend by 58.7% to estimate how much more than Medicare break-even they are paying to hospitals. That's about $2,280,000 a year, or roughly $190,000 a month, spent above the Medicare break-even rate. That's more than $2 million a year in potential savings opportunities for lowering hospital prices at hypothetical Company A. As another example, NYC spent $9 billion on health benefits for their employees in 2021. Applying the same assumptions, NYC has $2 billion in potential savings opportunities if their hospital prices are tied to Medicare's break-even rate. What could NYC do with $2 billion? Next, we go a bit further and look into what hospitals are charging commercial payers like us for some common elective inpatient and outpatient procedures. 32BJ Health Fund found that there is a high level of price variation even among common procedures and similar services. For example, we pay more than $55,000 to Montefiore Hospital for an inpatient C-section, compared with $27,716 at Maimonides Hospital, and an outpatient colonoscopy costs us $10,368 at New York Presbyterian, yet only $4,139 at Mount Sinai Hospital. And in both cases, these same procedures cost only $17,681 and just $2,100, respectively, at NYC Health and Hospitals. You can access a lot of this information because of some new federal requirements. Since January 2021, federal law has required that most hospitals post their gross charges and discounted cash prices, as well as their negotiated rates by payer and de-identified minimum and maximum negotiated prices in a machine-readable digital file. Similarly, for 300 shoppable services that can be scheduled in advance, the hospital must provide plain language descriptions and price information on a consumer-friendly public website. Although New York hospitals lag the country on compliance, this is still a rich source of information. You can get this data online from each of the hospitals your members use. This lets you compare your TPA's prices to what other TPAs or insurance carriers have negotiated for the same service at the same hospital. There are also vendors that can provide this data all in one place. When the 32BJ Health Fund looked at the prices we pay hospitals versus the average and lowest commercial prices in New York, we learned that the prices negotiated by our TPA could vary from hospitals to hospitals and are not always competitive. For example, we are paying about 35% more than the average commercial payer for vaginal deliveries at New York Presbyterian Weill Cornell, and about 160% more for colonoscopies at Mount Sinai. On the other hand, we are paying less than the average commercial payer at NYU Langone for colonoscopies. This is important information for us because we want to ensure that our healthcare dollars stretch as far as possible. The second important source of federal data comes from health insurance carriers and TPAs. As of July 2022, they must also disclose information regarding in-network provider rates for covered items and services, out-of-network allowed amounts, and billed charges for covered items and services. This data must be specific to the payer, like to the self-funded group, or to each filed health insurance benefit plan. That means you if you are a self-funded group. Early indications are that insurers and TPAs have been posting large amounts of data to comply with federal requirements, although it is still early to assess the data quality and premature to start using it. When it is ready, the groundbreaking opportunity provided by this data is that you will be able to compare what your own company is paying compared to other self-funded companies. This is invaluable when you are negotiating with carriers so that you are ensured a fair price. Stay tuned. Understanding the break-even point and the procedures that are driving up costs will help you negotiate with your carrier or third-party administrator and get the answers to the questions every CFO wants to know. Are you getting the best deal possible? Or are your competitors paying less than you? Armed with this knowledge, it is time to make a specific ask of your carrier or TPA. Explicitly ask them for the following. 1. Whether it will work with you to direct contract for better rates with network hospitals. 2. If your carrier has any provider's contracts that would prohibit you from A. Eliminating a high-price or low-value provider from their network, B. Creating a tiered network that differentiates between preferred and less preferred providers through levels of employee cost share. 3. If your carrier is willing to let you do any of these tasks yourself, and if they have done any of them for any other payer. Negotiation is important, not just for your organization's future, but also to help curtail hospital prices on a large scale. If we all ask for better pricing and better transparency, we will have greater resources for worker salaries and benefits and greater opportunities for investment. But it all starts with the ask. We have to start by acknowledging that affordability is a problem and work together to solve the problem for long-term affordability. Are you ready to join us in solving the problem?